Hi everyone, this is Dr. Jenny Nichols with IVFMD, and Dr. Duro is going to be joining me in a minute. Perfect, there we go. We are live. And everyone's starting to join in. It is rainy down here in Florida. I'm still showing my palm tree in the background, but we have had storms. Oh, there's Dr. Duro. We have had storms. I don't get to show you sunny Florida. Let's see if she's joining in. Accept. There we go. Hey, Dr. Duro, how are you?
Hey, how are you?
I'm good. I was just telling everyone, hey, and it is cloudy and stormy and rainy down here in Florida. So I said, I'll show you my palm tree, but it's rainy and disgusting back there in the background. So
Oh no, that means it's coming here in Miami.
yeah, I had my boys who usually bike to and from school. I'm like, yeah, you're not biking today. So I drove them to school and my parents picked them up off the bus, but I'm like, no biking. That storm is coming.
Well, it's a perfect for our Q&A
It is
then.
perfect. Yep. Everyone down here who are patients and that follow us, plus everyone else, can say, hey, it's not sunny Florida. I know my husband's in Pennsylvania right now and he said it's 40 degrees up there. So
Oh wow.
I'll
No.
still take rainy Florida any day.
Yeah, that's fine.
Plus, I have a nice little, I think it's going around the whole country, but a nice little junkie cough. So I have my tea. So as you hear me with my little cough, you can know
Oh
that I'll
no.
sip it.
Oh
I'll blame it on spring break. I caught something, but
yes, my daughter had the same thing last week. It's like, oh no,
yeah.
but it's going
Yep.
around. So
So how are you doing?
very good. Good. Yeah, that's springtime. We've had a lot of a lot of deliveries actually, a lot of patients delivering. So it's been exciting.
Yeah.
I've been posting
We've
on our Instagram.
we've been discharging a lot of patients that when our patients, to those who might not know, when our patients get pregnant, they follow us through a period of time, and then usually at around that 9-10 week mark, we say they're discharged from our practice, which a lot of our patients have a lot of angst and
Mhm.
anxiety about of leaving us. Um, And I say, to anyone who hasn't heard, I love my analogies. And this analogy is it's kind of like graduating high school. You're saying goodbye to that comfort and those friends and everyone you know really well, but you're moving on to the bigger and the better and the things you have to move on to be able to get to your goals and
Yeah.
moving on. And so I say, yeah, we know we're sad too, but we're so happy to be able to see you moving on to that OBGYN and that bigger and better. So
Yeah, graduation. That's exciting.
graduation, that discharge appointment and graduation appointment. And yeah, so we have
Yeah.
had so many people graduating recently. I actually even talked to a local OBGYN that said, oh, I saw so and so and they are so excited. And then the husband came in and said, oh, we're so ecstatic. So yeah,
That's the most rewarding part, actually.
yeah,
It's bittersweet, but it is super rewarding. And we see our patients throughout pregnancy a lot of
yeah.
times, and especially with patients that are having back pain and neck pain and migraines. Sometimes they don't really know that it's safe to do acupuncture because they're very
Hmm.
concerned. And understandably, it took a long time to get where they are. So, but it's one of the few things you can do for pain relief. So that's why we still see patients during that time.
Yeah.
But and right before delivery, we actually had two breech pregnancies. A gynecologist we work with referred them for acupuncture, and so I know one of them did turn. I don't know the other one. I'm not sure, but it was rewarding,
Yeah.
So.
So actually, we just got a question, which I'm happy to answer before I lose it and forget it. But hello, after embryo implantation or transfer, can you travel by plane or must you wait? And actually, I had this question recently. I had a gestational carrier. So sometimes we have gestational carriers coming from all around the country. And yes, you can travel by plane. Usually, we don't suggest, if at all feasibly possible, immediately after a transfer. That embryo is likely implanting, so we're transferring that embryo usually around the day 5-ish of the embryo status, and it's going to implant in the next day or two. So we don't suggest it if at all feasibly possible, in that next day or two after embryo transfer. Um, but yes, you can travel. I had a patient who was newly pregnant and said, "Can I be traveling in the next 2 weeks?" And I said, "Yes, you can." When I do tell patients they can be traveling by plane, I remind them that their estrogen levels are higher. I mean, they usually, when we do an embryo transfer, they aren't significantly physiologically higher than what they are normally, but I still remind them that they are higher and they're on the estrogen, and make sure that they're moving around, that they're not just sitting kind of stagnant on a plane, especially if it's a long flight. So moving their legs, flexing their toes, getting up and walking up and down in the aisle. And another thing to remember that you might not think about if you're traveling on a plane is if you've just undergone an embryo transfer, that you may be on medications that you might not normally be on. So a lot of the medicines we use, the estrogen pills and patches, are easy to travel with. The vaginal progesterone, fine, but the progesterone shots, be prepared to be traveling with those. And someone that is either able to give those to you, or where you're going, your destination wise, can give those to you. And so I had a patient who's getting ready, and she's going to be having her transfer in the next 2 weeks, and she was going to be going on a work trip about a week and a half after that. And she's like, "Oof, that's not going to work. I have no one at my work trip that is going
Mhm.
to be giving me my IM progesterone. That is just not
Yeah.
happening. I think I'm going to be changing that work trip." But then she said, "Oh, like 3 weeks after that transfer, when I'm gonna know I'm pregnant, fingers and toes crossed, she's like, I have a trip planned with my husband." And she's like, "He has to go. So I know I'm going on that trip with him because he's the one who's giving me my shots. So if he's
Mhm.
going and I'm not, then I'm at home, and then who's giving me my shots?"
Mhm.
Um, and so I think that's something, and we're happy as a practice, and I know other practices are, to write you a note saying that this patient must travel with her injections so that you don't have a hard time getting through security with them or anything else. But
I wonder about that with international flights. Do they ask questions about injections or
yeah,
hormones? So some countries.
I don't know, but I'm sure it's very similar, that as long as you declare things, because you figure people with diabetes and insulin injections and syringes have to travel with them. So as long as you're declaring it, I think, I mean, I know I traveled with breast milk and breastfeeding, not internationally, but I mean, you just have to be able to declare that breast milk and say, and then they test it and know what it is and know that it's not anything dangerous. But
Mhm.
it's a whole lot easier once you have a doctor's note in hand or something saying, "Yes, I'm allowed to travel with this."
Yeah, very good. And I noticed, well, actually, we didn't do our
Oh,
introductions, and maybe
yeah, yeah,
we
we
could
kind of
tell her.
skipped. I started, but let's go ahead. You can start.
Oh, okay. Well, I'm Farah Duro. I'm a refractive acupuncturist. I'm in Hialeah Gardens on the border of Broward and Miami-Dade, kind of right in the middle of the Cooper City and the South Miami location, actually, like right, the halfway point. So we do assist patients with transfers as well. We go to IVF transfers to do acupuncture on site at either location, and then we also, of course, provide in office treatment for preparation for IVF or IUI, or just in general hormonal balance, pain relief, and that sort of thing. But and also during pregnancy. So we actually have. We have a nurse on staff who is an infusion nurse who does interlipids now at our office too, with your patients or IVF and B patients and other. So that's been actually very nice. For patients, maybe we'll talk about this. I don't know if I saw an interlipid question or not, but someone asked me that this
There's
week.
definitely something that I can tie it into, or at
We
least I can
cannot talk
answer something in
about it a
relation
little
to
because
that.
I do get a lot of questions like, what is this for? What does it do? How does it
Yep,
work? So maybe
yep,
we can, yeah.
yep. So I'm Dr. Jennifer Nichols. I am with IVFMD. I'm one of the newest physicians with IVFMD. So we have multiple offices with IVFMD. We have, I know I'm getting really good at naming them all, but we have Miami, Boca, Cooper City, Jupiter, Naples. Tell me if I forgot any. But and then myself up in Vieira, which Vieira is east of Orlando. I am the furthest north and east. So I'm up near Melbourne area, kind of Cape Canaveral area. Yeah, I originally was up in Philly area, hence why my husband is up in Pennsylvania area with family, but and came down here about a year and a half ago.
Very nice.
And so now have been with the Viera office. Um, and yeah, happy to help patients and happy to talk with you tonight because it's always fun and exciting and answering lots of questions for patients. So we do have questions, and I think because we kind of started with that embryo transfer and travel question, I have no problem kind of banking off of that and saying some questions in relation to some embryo transfers and things to avoid and what to do. So we did get some questions. Should I avoid fragrances and plastics while trying to conceive? I think in relation to, yes, not necessarily in general, fragrances while trying to conceive. We do have people avoid fragrances the day of an embryo transfer because we know that they are especially strong in the IVF lab and that can affect the embryos we're transferring. Obviously, if you're trying to conceive and the egg is inside of you, the sperm is fertilizing inside of you, the embryo is traveling down the tube and implanting. That embryo is not as sensitive inside of your body to the outside fragrances. Now, definitely things like plastics, heating up your food in plastics, drinking out of plastic water bottles. There is a book out there of It Starts with the Egg. I have it in my office, but there is a lot of discussion about what can affect egg quality, both for young women with PCOS, women in general as they're trying to conceive, older women with diminished ovarian reserve. And it's not just egg quality that can occur as women age and affects definitely the egg quality that is known to occur as a woman ages, but it's also the what I explain to people is it's the possible egg quality that can occur from your outside sources that can affect the scaffolding of the egg. And that scaffolding is so important because what it's doing is it is as the egg divides initially before it gets fertilized, so it's extruding its extra chromosomes into the polar body, that can deem whether it's a good egg or not before it even is fertilized. And if that scaffolding is damaged, then you may have a poor egg to begin with. And then if that scaffolding is damaged as the sperm and the egg meet, then those chromosomes may not divide properly. So definitely you want to be your healthiest self. Things you can do to be your healthiest self, definitely avoid some of those plastics and the heating up in the plastic. The other things we say is overall inflammation in your body. Be on your healthiest diet. Try to be as healthy as you can. So obviously smoking, high amounts of alcohol. A lot of women, when they're trying to conceive, will stop or significantly decrease alcohol. Definitely as you're doing IVF, stop or decrease significantly. But even as you're trying to conceive, we want you to decrease. Usually the limit will start saying around like no more than like 4 to 7 drinks a week. And so that is just kind of a idea goal of, hey, try to limit. And it's because of that overall inflammation. Red meats. And so if people are asking questions, we'll say, hey, overall a Mediterranean type diet or things that can help reduce that inflammation in your body. So I would just say, and this patient or this person who asked this specific question online said she already knows she has endometriosis infertility and she's looking at doing IUI. So already we know she has some inflammation in her body with that endometriosis. And so what can she do to help calm that down? I don't know. Do you have anything else to add? Obviously, you know, as you do acupuncture, that there's definitely things that people can do and that can cause overall inflammation in the body and uh, that can, definitely affect them. But
We definitely tell you to avoid a lot of the air fresheners, things like that. It's sometimes they are not great. Sometimes they can, mess with, or they could be considered endocrine disruptors. So as things are happening, we just don't want more burden. We try to make sure people are going to the bathroom every day. That's actually adequate detoxification, like number two, because if you are backed up and then you
I'm
start
bad.
estrogen and all this stuff, it's kind of like it's to break everything.
So
So
something
we try.
it's good. People, I don't know what you recommend. Obviously, acupuncture helps that. But we'll tell people, I don't know what you think, but one of the things I tend to recommend to my patients is Colace. It's a stool softener. It's not necessarily a laxative, but Colace just helps people in general with that stool softener. Obviously, diet is ideal if you can get the inadequate fiber
Mhm.
and foods, but sometimes Colace will just help in relation to a general stool softener to help them go more frequently, especially when people get pregnant. I feel like that progesterone and all
Mm.
of the hormones, it definitely wreaks havoc in relation to the female body and the hormones and the GI system.
Yeah, I love probiotics for
Yeah.
that reason. There's Megaspore that I really like. They're doing some research on it, enhancing GLP-1, which is that peptide in your stomach, which are all these famous medications. They kind of mimic that, but it helps you feel fuller. So some people are losing weight just taking those probiotics.
Hmm.
We add them to our weight loss protocols, but we also work with them for fertility because there's a lot of research now about the microbiome
Hmm.
and affecting reproduction and recurrent pregnancy loss. So if we can look at enhancing that, that
Yeah.
definitely.
I'm a big fan of probiotics. We do probiotics a lot orally, but then once
Mhm.
I find endometritis and there's a question on that too, endometritis in the uterus, a lot of the time, especially if it's recurrent or we have a hard time getting rid of it, I'll use a vaginal probiotics that's compounded that'll help recolonize the good bacteria in the uterus area. It's a vaginal probiotics that they just put
Mhm.
in, and then it'll help colonize it so that that bad bacteria doesn't have a chance to recolonize.
That's great. Yeah, definitely. And I know that you guys recommend the same like I guess we're getting off the
I know.
questions right now, but we do I have questions from patients from during the week too that are in my
I
mind.
know.
So one of them is the vaginal probiotic before transfer.
Mhm.
You guys still use that like a
Yeah.
week before?
So not routinely, but I do in patients that have, leading up to it in patients that have had very bad endometritis or endometritis that we have treated and shown. So if we're doing specifically, if I have patients going through an MN analysis and we specifically nail down which bacteria we're treating, then we'll get them on a vaginal probiotics. And every cycle leading up into it until we do a transfer, then I'm giving them. So they'll get a bleed
Mhm.
7 days to recolonize to get that good bacteria in.
Okay, I think we missed a little bit of that.
So
You said you do it the
yeah,
week.
so usually I do. So if they've done the M and the Alice, then usually it's after they get their bleed. Then I'm giving them the vaginal probiotics for about a week.
Okay. Okay, great.
Yep.
And that's the endometrial biopsy, right? That.
Yeah, that's if their endometrial biopsy is abnormal and I'm treating them usually with like the MN, the Alice with a specific antibiotic. And I know I'm really wiping out that normal biome.
We have an endometrial
I
biopsy question.
do. It's a perfect one. Endometrial biopsy. When is it recommended, warranted, and what treatment to give? And that's almost a loaded question. So, endometrial biopsy, I think definitely, I always do an endometrial biopsy on people with recurrent pregnancy loss or irregular periods. Always, always, always. Even if they are just saying, "Hey, don't think I'm going towards IVF. I am considering doing ovulation induction." I think those patients warrant an endometrial biopsy. They have recurrent pregnancy loss. Do they have endometritis? Do they have something else going on in that uterus that is causing an embryo to not implant well? And the reason for irregular periods is, do they have hyperplasia or precancerous cells? If they aren't shedding off their lining routinely, I want to make sure that they don't have precancerous cells in their uterus, that it is something I need to treat before we get them pregnant. So if they have
Mhm.
PCOS or the irregular periods, they don't bleed routinely, they get 90-day periods. that I want to make sure that there's nothing abnormal in that uterus. Um, the and trust me, we found it. The Those are a definite hard stop that you're getting a biopsy. And I hate the word biopsy. I tell people, I say, biopsy makes it sound like you're taking a bite of tissue. So instead, if I say I'm going to do a gentle, like scratching of the lining, and when you do an endometrial biopsy, it's a teeny little catheter straw that has an opening in it that it goes in, and you kind of move it around inside the uterus. So it's kind of just an opening in the straw that's taking a little scratching of the inside lining that lining normally would shed off anyway. So it's taking tissue that would normally come off from the inside lining of that uterus, and it's just taking a sampling to get a good assessment of that uterine lining tissue to make sure I tell people, no inflammation, no infection, no precancerous cells. I also tend to do it pretty frequently, unless I know they've had a normal biopsy in the past, um, before an embryo transfer. Because the last thing you want is if they have any endometritis, inflammation in the lining, then I'm concerned that um, I'm going to give you another analogy, but then I'm concerned that there's inflammation in there. I don't always know that that inflammation isn't just because there's some irritation or inflammation versus is it caused by an infection. The most common causes of infection are mycoplasma or ureaplasma, although there are other things that can cause an irritation in there. But here's my analogy. Some of my analogies are better than others. This is one that maybe isn't so great. It is a good analogy, but let me explain why I don't think it's so great. Because it's comparing the inside uterus to a throat.
I can see it. Yeah. Okay.
Okay, so right now my throat sounds all scratchy and red and irritated. Okay, it probably is. If someone looked at the back of my throat, they'd say, "Oh, your throat looks red and irritated." Does that mean I have strep throat? No. Does it mean I need an antibiotic? No. Um, but it is red and irritated. Now, if I looked at it and it had pus, yes, give me an antibiotic. It is streaming red. So if I let someone take a biopsy at the back of my throat and there were plasma cells and the CD138, and like, I would say, yes, please give me. No, if I knew I was putting an embryo into the back of my throat, I'd say, give me an antibiotic regardless, get rid of that inflammation, because I'd be worried there was an infection back there. But just because there's an inflammation in the uterus doesn't necessarily means it's coming from an infection, although it is one of the more common causes. Sometimes I tell people it could come from a little polyp or something else in there, but if we've done uterine cavity tests and we don't see a polyp or anything else, it's probably from an infection or something else going on in there. When we find that endometritis, here's the next part of that question. There's my scratchy throat. What's that treatment? And that treatment is routinely an antibiotic. One of the most common treatments that a lot of people do is doxycycline, twice a day for 2 weeks. A lot of different places shift or do different things in the past, and sometimes depending on different allergies. I'm trying to look and make sure I don't lose this here. If you want to see it here, I want to not lose this question because I know one just disappeared from me.
What about a Z pack
Um,
for one day? I saw that.
Yes, sometimes the Z-Pak for a day, although usually then I'll make sure I rebiopsy. And usually I'll rebiopsy. Cipro, twice a day is a good one. Sometimes Augmentin or Levaquin, but usually we'll add Flagyl with it. So there's a lot of different treatments, and they have been shown to be effective because what it's doing is kind of saying, hey, we're killing that bacteria in there. Now, a lot of the time, especially if someone's going to an embryo transfer, um, um, I'm writing this down so I don't forget this question. So is that if you're going to an embryo transfer, the question becomes do you do a repeat biopsy to prove whichever one of those antibiotic choices I just mentioned, that it's gone? And usually the answer is probably. It's probably worth proving it's gone. Now, if it's not gone, what do you do? Rebiopsy, try a different antibiotic. So if you've rebiopsied and it's still there, try a different antibiotic. one of the things sometimes then I offer and talk to my patients about is considering the Emma and the Alice. And let me explain what Emma and Alice is. It is a newer testing technology in which it is using microarrays to see, hey, which bacteria are present, and it's checking for a panel. And I think the last time I looked at the panel, it was something like 23 different bad bacteria
Mm-hmm.
and checking for 5 good bacteria, lactobacilli. You want the lactobacilli in there. You don't want any bad bacteria in there. And so what it's doing is it's the same idea of a biopsy, same scratching of the lining, and you send this tissue off and they give instead of, hey, nope, there's inflammation, or hey, there's no inflammation, they give a more concrete type data of, hey, nope, there's none of these bad bacteria, or hey, yep, there's bad bacteria, this one, this one, this one, hey, there's no good bacteria, or hey, there's good bacteria but there's these bad bacteria. And the nice thing is, once you nail down which bad bacteria exist, you can treat more evidence-based with antibiotics instead of just, hey, let's treat an antibiotic but we don't know specifically what we're
Mm-hmm.
treating. And so usually the first round I'll say, hey, let's treat because we assume it's probably mycoplasma ureaplasma, and if it goes away, we're good. But if it's not, or if I know someone's had recurrent endometritis before, then I'll go for that Emma Alice. Usually once you get that Emma and Alice, you do want to do a repeat biopsy to prove that which those of bad bacteria were there are now gone. And then that's when I'll start saying, hey, vaginal probiotics. Why? Because I use specific antibiotics to kill this, this, and this, and I want to recolonize and prove that, hey, even if you had good bacteria, I probably just wiped them out with my antibiotic choice, and now I'm going to recolonize it.
Interesting. And do you guys still give antibiotics before an HSG,
Um,
or do you recommend?
so an HSG and an SIS, but not in the same doses. So before I said doxy for 2 weeks for endometritis, we give the doxycycline for 2 days.
Oh,
Like, it's a teeny mini dose.
okay. Because I always wondered when you hear people go, "Oh, I got pregnant after an HSG." I wonder if it was from the
Yeah.
antibiotics
And,
sometimes.
and truthfully, probably if someone had like a teeny little irritation of their throat or a teeny little irritation of the uterus, maybe you just wiped out that little teeny irritation.
Yeah.
Or the HSG more so, because what we're doing is, and you'll see it when you do an HSG, is you're flushing those tubes. And so maybe there was some mucus or, something in it and you flushed it open,
Mm-hmm.
especially when you're using that X-ray dye because it's a thicker X-ray dye. And so hopefully you're pushing something that maybe was in or blocking that tube out, and then they have that increased chance of conception.
Good.
So I
More.
think we answered some of that. So I think this kind of falls right into there. What is the best recommendation for recurrent miscarriage with normal lab work and IVF? And I think I did talk about a little bit of that. Definitely consider an endometrial biopsy. I think the only other thing sometimes I'll add in is consider like things like antiphospholipid antibodies. This is where you and I can talk now about, hey, consider natural killer cells, because if those things are abnormal, I tell patients, I'm not going to test anything that I can't treat. But if I test antiphospholipid antibodies, or definitely with recurrent loss, lupus anticoagulant, cardiolipin antibody, beta 2 glycoprotein, if I'm testing those things, then I find karyotype on patients. So I mean, if all that lab work is normal, but if natural killer cells, so if the natural killer cells are abnormal, what are we doing different? This is where you can start talking about it too, although we obviously do it in our office because my office isn't too close to yours, but intralipid infusion. And what I explain to patients is that natural killer cells is showing that there is some reaction in your body, and that intralipid is helping to calm that down. And so by giving the lipid infusion, and you can say, I think you guys are probably doing it based on what we're recommending too, but I just explain to patients very basically of, hey, we're giving you intralipid during your uterine prep. right as your embryo transfer is occurring, and then into and through the first trimester.
Mhm.
And it's in theory helping an embryo implant when normally it may not. And we usually see a positive natural killer cells in a lot of people that have something autoimmune or something else going on.
Or they're extremely healthy. I would say if you're the type who never gets sick,
Yeah,
your natural killer cells are probably working really
yeah,
well, and they're
yeah,
just working too well
yeah.
as
They're
far as
working to against that embryo. Yeah,
right. And this is kind of boy, is the way I've kind of understood it to
yeah,
be, but.
yeah. It's kind of helping, so helping calm it a little.
Mhm.
Yep. So let's see. I think I got that. What are my chances of getting pregnant in my first IVF cycle with a 26-year-old, probably 26-year-old egg? So I think this is a good question because I'm going to assume that it's not doing genetic testing on the embryos for a 26-year-old, but I can kind of say with or without genetic testing. And so the idea with IVF, obviously, taking a woman's eggs out of her body, mixing them with the sperm, and I think this is really just kind of assuming we don't know why this woman isn't getting pregnant. Um, and whether it be a tube factor, a sperm factor, or anything else, but you're overcoming it at that point. So eggs out, mix them with the sperm, embryos growing and dividing. You now have a good quality embryo. The question becomes at this point is you have two different directions you can go in IVF. You can either say with genetic testing or pre-implantation genetic testing, PGTA for aneuploidy, meaning the embryos are being screened to see if they're chromosomally normal. So showing are the embryos chromosomally normal? Not necessarily done in women less than 35. Why? The majority of embryos, I won't say majority, but a good number, usually over 60% are chromosomally normal in women under 35. But once that woman hits, and now I understand this woman who asked this question isn't, but she's under 35. But once a woman hits 35 or older, in a 35-year-old, then you have more like 50-50. So 50% of the embryos have a chance of being chromosomally abnormal and 50% normal. So then there's some benefit to being able to screen the embryos because it can increase your chance of success once you know you have a chromosomally normal embryo, because you have a higher chance of putting in that normal embryo and it growing and dividing and progressing. And so in a woman who is 26, if the embryos were not screened, which is fine, um, then I would say the overall chance of success we would quote is about 50 to 60%. That's national average, that's statistical. And it's, I mean, definitely if it's because there's a sperm factor, there's a tube factor, you know, you are overcoming those, and there's not something specific of, well, your unexplained infertility. Is there something with your uterus? Is there something else going on hormonally? Do you have something else, natural killer cells that's not being tested that we're putting in an embryo? Do you have something else autoimmune? Do you have something else, endometritis, whether that was or wasn't tested? But in general, I would say that should be your chance of success. Now, in a genetically tested embryo, although in a woman less than 35, it doesn't go up hugely significantly, it does go up and it's about 65 to 70%. Now, obviously, in a 35-year-old, it's lower in an untested and the same across the board in a tested. So that in general, and fingers and toes crossed in your first IVF cycle, the chances are really good. And the other benefit in a young woman is hopefully you have a lot of embryos so that hopefully that first cycle is successful and you get pregnant. And if you do, amazing. And you have other embryos frozen for baby number two. If you don't get pregnant, then figure out, is there something else that should be looked at? Uterus, any of the other testing we kind of just talked about, and then can look to the next embryo. But hopefully don't need to, and that first embryo is successful.
Yes. And then we have a question also about someone's having their FET in 1 month and they want to know what can they
Yep,
do to help
yep,
with increase
yep.
success.
Thanks. I had to have that translated. I don't speak Spanish. My goal before I moved down here was to learn Spanish, medical Spanish, for so what I needed, and now I'm too busy. I still have not gotten there. My husband started learning Spanish, and then I fell off by the wayside. So yes, advice, diet, anything specific. I think we talked about some of the diet. I think in general it is follow, and this I tell to everyone, follow your clinic and your doctor's recommendations. Do what they're saying, follow your medicine protocol. In general, try to stay as relaxed as you can. Um, and just trust the process. The process works and is good for a reason. It is getting the best quality embryo into your uterus, and it is giving you a far higher chance of success than anything else you can do naturally or anyone can do. But I think in general, just try to get the best sleep you can, try to eat the best you can. No smoking, obviously decrease or eliminate that alcohol. And in general, just trust the process.
You're very good. Yeah, I agree with everything. And we try to, well, we have a few acupuncture questions, so I guess we'll tie those transfer acupuncture
Yep, I think
questions.
I have one more FET question that let me throw in there because we have it. On day 5 of 5-day FET, haven't seen any implantation and I'm freaking out. That's okay. You don't have to see implantation. So some women are like, oh, I see implantation. I have spotting. That's definitely a good thing, or we'll feel it, or it does not necessarily mean it's not happening or it's not working. It's okay. Um, Heck, I had a friend who did IVF and she didn't think it worked. She said there's no way. Let me even tell you an even funnier part of it. Now, okay, she's a doctor. She went to the dollar store to buy her pregnancy test, her home pregnancy
Mhm.
test. She peed on a stick the morning because she knew she had to drive to the clinic to go get her HCG, but she still peed on a stick. She called me. It's negative. It didn't work. There's no way. I said, okay, that's great. I feel really bad for you. I'm sorry. You have another embryo or two. It will work, but I'm really sorry, but you still have to drive to that darn clinic. It's 30 minutes away. I know. Drive to that clinic and give them your blood. It's negative. It was positive. She is a little girl from it. She's
Oh,
like, darn pregnancy test. I said, okay, it didn't. Later, come to find out, she got him from the dollar
probably a
store. And I'm
bad.
like, bad batch. I'm like, you could probably have your husband pee on it and it would be positive.
Oh no.
And I'm like,
Oh man.
so yeah, she had no symptoms, no nothing, no implantation spotting. Like that, I mean, some people notice it, some don't. And I will keep my fingers and toes crossed for you that it is still going to be a positive. The freaking out is sometimes something you can't avoid. And some patients, and we've all heard it and been here, some people will do the urine pregnancy tests until they like see it, a fainter line, a stronger line, a stronger line, and take photo documentation of it. We've all seen it on social media. And some people do not want to test at all and don't want to look at it.
No.
And so you can be either camp of those patients, and that is fine. You do what makes you feel emotionally happy.
Hmm. Hmm. Yeah. Yeah, it's so hard, but it's 10 days of agony. I
Yeah,
know.
it is. It's the tortuous wait. Just do what puts you into your happy spot, gets your mind off of it the best you can. And if peeing on 20 million sticks somehow puts you into a happy mindset that you think it's getting darker and then you feel a little better about it for 10 minutes, then pee on it 20 million sticks. But realize you're spending a lot of money on sticks.
That's true. Good advice for sure. And you can have low betas and still be okay. Like we had
Mhm.
patients that a little like it wasn't, in the triple digits or anything, but they had a positive pregnancy test and it started off a little low and then it went fine. So
I'm
sometimes
looking and seeing if a prior patient of mine is on, and I won't even mention a name, but hers started out low,
mm,
and she can wave if so, but hers started out low, and she has a little girl now from
oh,
it. So,
oh, that's awesome. There was a question actually, maybe we missed this with 32 eggs.
yeah, I saw
Someone
it. I wrote it down. 32 eggs, if you saw it any more than me. So 32 eggs, I think progress to one embryo. Is there when do I get a second opinion, or do I get a second opinion? I think the nuts and the bolts of what I got out of that is, do I get a second opinion? My answer is, get a second opinion whenever you want to get a second opinion. There is no wrong time to get a second opinion. And whoever wrote that, if you want me to answer anything else, feel free to type it in. Second opinions, there is no downfall to that. And truthfully, any doctor should tell you the same, that if you feel or question that you want a second opinion, I tell my patients, feel free to get a second opinion, and you can decide who you feel comfortable with, whether you stay with your current doctor or go to a new doctor. Don't ever question getting a second opinion. Any data that this initial doctor has can be transferred to another doctor. Any of that testing. If they want to get new testing on certain things, they may, but any of the basic testing, the communicable disease testing, the genetic testing, that will all be easily transferred. And that is not a big deal. They may want, I mean, and if you have an embryo, the embryo can be transferred. That's now certain labs do have dot their I's and cross their T's and make sure how the embryo looks and how it was frozen and what was done. And you do have to confirm that the lab will accept the embryo, but that's fine. Get a second opinion, talk to the doctor, see what they would do the same, see what they would do differently. Definitely.
We missed a question earlier that was saying they're asking if you have any existence around Tampa, like you have any clinics around
we have Naples area. So
Okay.
that's about the closest to Tampa area.
And there was a question also about like the timing, the process, or how long is the process from egg retrieval to implantation?
Yep, good,
But I guess
good question. So in general, yep. So egg retrieval. So let me start from the beginning. IVF is kind of a two-step process. There's the step where we make the eggs and the embryos, and that process in general takes about 9 to 12 days to stimulate and make the eggs, and then a day and a half later do the egg retrieval. Usually a woman's period after that egg retrieval comes about a week and a half to 2 weeks later. So going to get your period. So in theory, like 2 weeks to stimulate, egg retrieval, 2 weeks later, a period. So really, it's about a month from, I mean, short of sometimes women are on pills at that beginning stage before you start the stim, but about a month to be able to stimulate, make eggs, make embryos, and get a period. Now, depending if you're doing the genetic testing, once the eggs come out, are fertilized, grow and divide, make it to that blastocyst stage, and if they're biopsied, if they're just frozen, they're frozen, and now waiting for a woman to get a period. And then we roll into the second stage. If they're biopsied, then you have to wait for that biopsy result to come back, which can take anywhere from usually about a week and a half to 3 weeks, depending on the lab. And the labs are getting more specialized. We're doing something called PGTA plus, and so they're adding a little bit of extra things with it. But in general, I would say that I'm going to make sure I'm plugged in. I don't want my phone to die. I have a charger right here. And so um, I'll finish this comment and then I'll let you answer some questions. It's not going to die quite soon. It's been a long day at the office. And so then the second part is usually when a woman gets her period, is if we know we're not going to stimulate her again. So there's my pre-warning. If we say, hey, we biopsied 3 and she knows she wants 3 kids, we may say, hey, that might not be enough. Do we want to stimulate you again? And we might not be putting her on a birth control pill. But if she gets her period and we know, hey, we biopsied 5 embryos, you know you want 1 child, hopefully we have at least 2 normal, 3 normal out of that, then we may be putting her on a birth control pill to calm the ovaries down, to be able to do any additional testing if we need it. If she hasn't had her saline sono or hysteroscopy, doing saline sono hysteroscopy, doing the endometrial biopsy if need be. And then what we're doing is planning on getting in the second part of that IVF, getting the uterine cavity ready. And that is usually with medications, although it can be natural depending on what a linings look like before on medicines, what a woman prefers. And so if it's a medicine cycle, usually estrogens and progesterone in different forms. We usually do estrogen pills, estrogen patches, vaginal progesterone, and shot progesterone. And that's usually a period of 2 weeks of the estrogen, kind of mimicking a woman making an egg, where the lining would plump up. And then progesterone, it's exposure of progesterone for a period of approximately 6 days, as if her ovary had released the egg had fertilized, the embryo was traveling down the tube, and it's now implanting, just kind of mimicking what happens naturally. And then what we do is we thaw the embryo and transfer the embryo into the uterus that day of transfer after the exposure to the progesterone. And so, in theory, to answer that question, is from the time of retrieval to the transfer, it's going to vary depending on, hey, how long does it take for that genetic testing of the embryos to come back? But so you don't have to wait. So you got a period 2 weeks later. If you don't go on a pill, then you're waiting for your whole next period a month later because you've already started making an egg. If you go on a pill, then as soon as the embryos are back, it really is only taking 2 weeks and 6 days, or about 2.5, 3 weeks, to prep your uterus and do a transfer. So really the holding pattern is, hey, prove we have normal embryos and get ready and put in an embryo. So it's really just the prep time of the uterus in that second part. It doesn't take long to get the uterus ready. It's just, if you did genetic testing on the embryos, prove we have a normal embryo.
I always say to people that the hard part is the stimulation and getting the embryo. Once you have the embryo, it's like the prep for a frozen transfer is way less stressful, I think. Less medical.
Short of the IM progesterone, I say.
Well, yeah, that too, but I think, the whole
It's the
thing that we see,
buildup.
yeah, it's like,
Yeah.
am I going to have anything, that's good? Like, is this going to work? Like, am I, once you have those embryos frozen and they're genetically healthy,
Yeah.
your success rate is
I'm
very
gonna
good, I
plug in.
think. Yeah.
Give me a sec. Okay. So I think we answered a lot of the IVF questions. If you want to answer some of the acupuncture questions, and if anyone else has any along the way, then we can just feel free to ask them. But
Yes, there's a question about should you have acupuncture or do you have acupuncture in IVF, and then the timeline of it, and we do a lot of studies on our Instagram. We post a lot of interesting research, and the latest one was about FET and acupuncture. So that was in Fertility and Sterility a few months ago. That research came out regarding the success rates, if it improved it or not. It did show some improvement if you look at the research there. Depending on, they looked at when was the time frame and that sort of thing. A lot of the research actually starts a few weeks before the transfer. It's not just day of, but sometimes, if that is the only time we can see the patient, we will, join them at the transfer. I think it will help a little bit with some stress relief to help with blood flow, but we try to see patients before that. And I think any acupuncture is better than none, but at least our timeline is usually a few months when someone's actually calling to make the appointment with you guys, and maybe it takes a few weeks to get in, or it just takes some time to do the testing they need to do. Then we can use that time to our advantage. Try to work on reproductive acupuncture. Also, on their diet, we give recipes for the Mediterranean diet. We work it with their supplements. We look at what their blood work is showing and that sort of thing, to see if we can help. Like, if their vitamin D is low, we have time to bring that up so that while they get to you guys, hopefully that's looking a lot better. And if they have cloudy cycles,
which is shocking, even down here in Florida. I used to tell
yeah.
people in Pennsylvania and have people convinced that theirs wouldn't be low. But a normal vitamin D is 30 to 100. I like it over 40 in my patients. And I don't think I usually come across, most of my patients are in the 20s, like 27, 25.
Yeah.
And we live in Florida.
But it makes sense because everything, has UV coating. Like our cars, our office buildings, none of the windows open anymore.
Sunblock, everything.
Yeah.
Yeah.
Yeah, we're very shielded, unless we're actually exposing most of our skin during our lunch break outside, like wearing a bathing suit, we're not going to get much from the sun. But that's something we can work on those. If the thyroid is a little suboptimal, sometimes that sort of thing. Like if it's very just borderline, we can help with that. We have time to do these things, and we really do focus a lot on stress relief as well. We bring in meditations. We try to work with, our massage therapist does fertility massage. So all those things we can do beforehand. Obviously, pain relief. Like a lot of patients have migraines, and going into pregnancy with migraines is not optimal either, because once you're pregnant, sometimes either the medications can make it better or worse. So we try to work with that as well. There are good treatments for that with acupuncture. So that's our protocol. Is before the transfer, we do twice a week treatments that 4 weeks prior, and then after the transfer, we're treating twice a week till the ultrasound shows a heartbeat. Then once a week during the first trimester, and then as needed. And most patients, we tell them, do what you can. Like there's no hard and fast rules. You have to do X amount of treatments, but definitely at the transfer, if we are doing acupuncture there, we do the protocol from Germany, the original one that was done, many years ago, that showed a 30% increase in success rates. And we look at it like we're going to do exactly that protocol. We're not going to deviate from it, because it's been used for many years. And those points are done immediately before and immediately after the transfer. So they need to be done during that timeline. We don't recommend going to the office or going to another clinic and doing that protocol afterwards, because there is research that shows that wasn't favorable. So those points are actually meant to do what they're supposed to do during the treatment or the transfer. And then after that, we don't use them anymore, actually, during early pregnancy. We use them at the very end, right before delivery. So we try to look at that scenario. And I think with most patients, they definitely say, I'm so glad during, because it is it's a nerve-wracking day. There's a lot riding on that transfer. So we try to do our best to kind of get things a little calm before that, speculum goes in and everything happens. So that's our protocol.
Yeah, I mean, I think where I am now, it's a little harder because we don't have a fertility acupuncturist right where I am. We do have, and with your help, I have found some in the area. And I would love to, if anyone knows anyone in our area up in Viera, Melbourne area, definitely reach out to me and call the office. But yeah, right now I have had a few that patients will go to, but no one that's coming into the office routinely or ever since I've been here. And I haven't been here that long, but I'm a little jealous of the patients down in Cooper City and Miami and what you guys have. So
Maybe I can look on our forum. We have a reproductive acupuncturist forum, so I can definitely jump in there.
yeah, yeah.
But either way, it's something to do with, I think, relaxing the nervous system, trying to get to that parasympathetic mode where you're not in fight or flight. You're trying to, calm that. And it sometimes takes a few treatments, but also I recommend yoga, which is excellent. So like restorative yoga or fertility yoga is very gentle. It's not the power yoga or the hot yoga or any of that. It's basically 2 or 3 postures, but it's kind of like the lazy person yoga, which I really like. And some people just fall asleep when they're in those poses. It's really nice. But that's really helpful to do. Something you can do as a couple too, which is nice.
Awesome. Does anyone else have any questions on here?
We had one that about a 3 AB embryo.
Oh, I did not see that, but let me scroll back. Here, I saw one I missed. I'm getting endometriosis surgery on the 19th. How long do you recommend before waiting for the implant? So as long as you have the embryo, the good news is before you stimulate, they do, and more data is coming out that really after endometriosis surgery, stimulation, your AMH will plummet, and sometimes it takes a little bit of time. But if you already have the embryo, I would say follow your doctor's recommendation, but Um, Endometriosis, definitely you stand to benefit from suppression of endometriosis. So a lot of the time, if you're looking to do surgery for endometriosis, it's likely because of pain and issues, because there's other ways to sometimes suppress the endometriosis besides surgery, including things like Lupron or Orilissa. And if we are using things like Lupron or Orilissa, we'll look to suppress the endometriosis for anywhere for 2 to 3 months. So if you're getting the surgery for the idea of suppression of endometriosis before an implantation, then I would say probably the benefit of, if you're removing that endometriosis, at least a goal of helping it to calm it down for up to 2 to 3 months. But there may be some benefit of possibly even having going on Lupron or Orilissa after the surgery to keep it suppressed, and any small little implants to keep suppressed as well, with a something that may, and what Lupron or Orilissa are doing, if you're able to tolerate it, would be to put you, I mean, in theory, in a little bit of an artificial menopause, because it's causing your hormones to not allow that endometriosis to be active, and so it's really just kind of burning it out and keeping it calm. And so there may be some benefit to that even after the surgery, but I would say definitely a little bit of time after, not because I think you need recovery time, but because I think you need the benefit of what the surgery or that suppression may give you. I'm keeping scrolling to see what other, interested in knowing the recommended frequency. Oh, we already got that, of acupuncture leading up to FET as well as implantation. From cycle day one, how long is, we got that? From egg retrieval to implantation, we got that. I love these lives. Thank you. We like hearing that. That's why we're doing them. We got that. Existence in Tampa, but we're close. Dr. Alfred is down in Naples. She would love to see you. Um, let's see. Anyone who asked the embryo question, I'm not seeing it. So if you still have that question, feel free to ask it, because I am not seeing it. Um, oh, no, but that was the 32 eggs, whatever, a second opinion. Thank you for, oh, up, I found it. I have a 3AB embryo. What are my chances of implantation? So I think that question goes back to, so every office and lab judges differently. So a 3AB, if it's similar to how we judge, I would say it's probably not fully plumped up, although we grade a 6 as hatching out. So um, but every lab has a different grading system. So you really have to talk to your doctor and your lab of what does a 3 mean. Is that fully plumped? Is that not? I would say an AB sounds good. A is inner cell mass. That is the highest grade it sounds like they can give it. Although I have come across offices, labs that go backwards in those, but it usually A is the highest grade possible for an inner cell mass, what becomes the baby. B, trophectoderm, what becomes the placenta, really, really good. So usually I say A, hundreds and hundreds of cells. B, lots and lots of cells, both really good. So that 3 is the only thing I would just say check with your office lab, but it sounds like a really good embryo. I guess the only question is, I don't know if it's euploid or not, meaning chromosomally tested and normal. If it's not, then that fully depends on your age at the time. If it is genetically tested and normal, it's a good quality embryo, and really regardless of quality, it means it made it to blastocyst. It's a genetically tested embryo, and the chance of success would be based off of that, which should be statistically per the national average 65 to 70%. If it's not a genetically tested embryo, I would say based on age, in a less than 35-year-old should be 50 to 60%. In a 35 to 37-year-old should be about 40%. And in a 40-year-old should be about 20% in a blastocyst, nice progressed embryo. So Fingers and toes crossed. Thinking of endometriosis surgery. Oh, this kind of answers the question I said. They think I have stage 4. How long do you recommend waiting to implant? Oh, so that was the question, and I think I answered it. So as long as, yes, so as long, take it out because you have stage 4, you have pain, but make sure that you have the embryos you need, because taking out and wiping out all of that endometriosis, you are probably not going to stimulate well in the future. If you need to make more embryos, it's probably going to significantly lower your anti-Müllerian hormone. Just be aware of that. I think here, currently going through, man, more questions were asked than I thought I realized. Currently going through IUI first round with Clomid, only second round, which is the one I'm currently on with Clomid and Avidril. What are these for? So I think the question is, what are these medicines for? These medications are called, Clomid is, and letrozole are ovulation induction agents. They are there to help make the ovaries make an egg, or sometimes more than one egg. Um, they are really, we have 2 types of treatments. We have ovulation induction agents with inseminations or IVF. The ovulation induction medicines can help the ovaries make an egg, sometimes in a more timely basis, especially in women who don't ovulate necessarily regularly. And then we can give a medicine trigger shot to make a woman release that egg or eggs, and then time and insemination to get the sperm closer to those eggs. In the big scheme of things, though, those type of treatments aren't doing much more than what would happen naturally. We're still saying, well, we hope it's a good egg. We hope it releases and travels down the tube. We hope the sperm finds it and fertilizes. We hope it grows and divides. We hope it makes it to the uterus, and we hope it implants. These type of treatments in women who aren't ovulating can help women ovulate. These type of treatments require at least one open tube, preferably both open tubes. They require adequate sperm. If the sperm is a little bit lower, the insemination can help. But a lot of the time, if you have unexplained infertility, are you really overcoming what is the downfall, or what's occurring on a cellular level of, hey, is the egg even fertilizing? Is this, and the sperm getting into it? Is the embryo growing and dividing? Because we don't know what's happening inside of a woman's body. So to answer that, oh, and the Avidril is what I was saying, that trigger shot medicine to make a woman ovulate, is what that Avidril or HCG, Pregnal, Novaril is. So the answer is yes, these types of treatments can be beneficial, but I would not suggest them for a prolonged period of time, because if they're not working, then the second type of treatment, which is what we've spent a lot of time talking about, of IVF, is where a woman takes shot medicines to make her ovaries make eggs while she's asleep after after 9 to 12 days of taking those medicines. Then we can sedate her. She doesn't feel or remember a thing, and we can take those eggs out. Now we see those eggs in a dish. We see which eggs are mature. We can fertilize those eggs with the sperm, either by laying the sperm on top, or more frequently, injecting the sperm into the egg, so we know a sperm gets into every egg. We can see which ones fertilize. We can see which ones are growing and dividing. We can genetically test them, especially, which we've already talked about, depending on age. And then in the next cycle, once we know the lining is perfect, we can thaw and put an embryo in. So we know the embryo makes it into the uterus, and the only thing we can't control is, will that embryo continue to grow and divide and implant? But we've taken out a lot of the questions. We know there's eggs. We know the egg is mature. We know which ones fertilize. We know which ones are growing and dividing. We may even know if they're genetically normal, and we know what makes it to the uterus. So you're taking your chance of success from, depending on age, even in a young 25, 30-year-old, from 20 to 25%, in a 35-year-old from 15 to 20%. Now, this is even in a couple who has not tried to get pregnant at all. Now, in our infertility couple, lower. So from 10 to 15%, maybe 15% to lower as the age increases, to that if genetically tested, what I keep saying, that's 65 to 70%. So that hopefully kind of helps answer that question in a really big nutshell.
No, I think we got to
Yeah.
everything.
I think we did too. So awesome. So, oh, one last: 3 failed IUI, 3 mature follicles, sperm count greater than 10 million, chances of pregnancy, age 33. So once you've done multiple IUIs and if it's not working, in general, at the age of 33, I would say the chance of success should be about 10 to 15% about. But if you're not getting pregnant, it would be worth considering moving on. If everything looks good, tubes open, uterus normal, sperm normal, and you're not getting pregnant, then it's time to have a talk. And I think that's it. I think we succeeded.
Yay. Excellent. That was great. Thank you guys so much for the
Yeah.
question.
Take care, guys. Thanks for joining us. Have a great night, and we'll see you next time.
Thank you very much and have a great night. Have a great week.
Yep. Take care, everyone.
Bye. Thank you.